You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Hello, everybody, and welcome back to yet another episode of the Nailed It Ortho Podcast. My name is Dr. Cole, and you are, again, tuned into the Nailed It Ortho Podcast. And today we have an interesting topic for you guys. We have another spine topic. It's been a while since we did some spine on this podcast, but today we are bringing it back to you all, ladies and gents. And today we're going to talk about lumbar interbody fusion. So again, lumbar interbody fusion is what we're going to talk about. And we have Dr. Andrew Zhang. And Dr. Andrew Zhang actually completed residency in Louisiana at LSU Shreveport. So shout out to Louisiana. He completed a couple of spine fellowships, and he is currently a spine attending. And he is actually out crushing the game. And we talk about interbody fusion today. We talk all about different types of lumbar interbody fusion. We talk about ALIFs, or anterior lumbar interbody fusions, OLIF, XLIFs, PLIFs, all the different lifts, the alphabet soup, we still call it. So this is something that I knew a little bit about in residency, and then you read for the exam for when you do your orthopedic exams, but you don't really read about XLIFs and all these other different lifts. But there are some test questions on it, and it's really interesting stuff, interesting things to talk about. So without further ado, I hope you all enjoy today's episode. If you're listening on Spotify or listening through one of the audio channels, go and check out the YouTube channel. And if you're watching this on YouTube, great, because we have some accompanying slides. That way you can see some of the things that we're actually talking about. So without further ado, let's go ahead and hop into today's episode. Dr. Zhang, welcome to the Nailed It Ortho Podcast. So happy to have you on. So welcome to the podcast.
Hey, thanks, Dr. Cole. I know we've been trying to do this for a while, and I'm really glad to be here. Yeah, finally glad we can make this happen.
Glad we've been able to do it. Yeah, it's been a while. I feel like it's been a couple of months we've been trying to set this up. Yeah, it's been a
long anticipated wait.
That's it.
That much. Yeah.
We don't have a ton of spine episodes. I think we have like the basic spine stuff, but this is this talk is like good for, especially if you're on a spine rotation, because I remember reading the normal stuff like for OITs, and then you get in the case and be like XLIF, and I'm like, what are we talking about here? It just completely flew over my head. So I think this will be like a good talk to talk about interbody fusions and what it is, and dive into the weeds for a little bit.
Yeah, I know you're absolutely right. And so, I remember when I was in residency training, we only had like one spine surgeon. So all is what that surgeon does, right? And then there's the full gamut of things that, unless you have a full complement of spine surgeons that are well-versed in a bunch of different surgeries, then all you really know is that one or two procedures. And so you're right. You could be sitting there for the OIT and not know what they're talking about. What is an XLIF? What's a DLIF? What's an LLIF?
Yep.
Well, they're all the same thing, so.
Yep.
Hopefully this can provide some insight and hopefully help out for that in training, which is in a couple of days. So good luck to everyone.
Ooh, man. Yeah, it is soon, right? Yeah. I do not miss OITs.
Nope.
Not at all. And so what we do typically is beforehand, we just ask a couple of questions to our guests, just kind of get to know you a little bit better. And so one of the age-old questions, because, we have residents that listen to this too, as well as, attending physicians. But what's one of the things that brought you into this kind of the field of spine? What drew you towards it?
Spine surgery is very, either you love it or you hate it, right? And so my initial draw to surgery was actually cardiac surgery. And, I loved the finesse, the intricacies, the tenacity of cardiac surgery. But, I was really drawn to being able to help a whole multitude of patients, which is what drew me to orthopedics, right? And so spine surgery is very similar to cardiac surgery in that it has the same kind of demands, the attention to detail, the fine motor, skills that you need for it. I think those are the things that really give me pleasure in this field, and so it's what drew me to it.
Yeah. And do you have a favorite case? I know you've finished your training, so you've seen like a wide array of all different types of cases. But do you have a favorite case that you've enjoyed being a part of so far?
Oh yeah. What really brought me to my decision of pursuing spine surgery was scoliosis, right? Scoliosis surgery
Yeah.
complex deformities. Yeah. If
Oh
you can
man.
take a look at my office, it's peppered with all these models that we had, with Dr. Lenke. And so, just these wild scoliosis cases that I just love taking care of patients with.
Yeah, I remember those cases. I remember them when I was on my peds rotations, like those 9 hour, those long spine cases. And I was like,
Oh,
there's a
yeah.
special person for this. It's not me, but I'm glad it's you.
Yeah, that's right. You either love it or you hate it. And,
Yeah, yeah.
unfortunately, I
But I think
loved
it's
it.
still
So,
cool though. Even just the different ways when talking about scoliosis and how you correct it and define stuff like you were talking about, like the pontiostiotomies and all these different correct, just the different angles. Like you got to be a brilliant guy and really smart to, understand that and be able to fix these really complex cases that you do. And this is so kudos to you, man. You're ahead of the game. Just for even just understanding all that.
well, I appreciate it. Yeah, I mean, yeah, send them my way. I'd love to take care of them.
Yeah. And so today, well, actually, one more thing. You're just starting off, we're early, you and I are early on physicians into practice, right? I'm a year out, which is really not that much further than you. And, you're just starting off. Anything, that you noticed starting off that you're like, oh, I didn't realize that this would be the case, or any, just a new physician thing that you didn't really know about, or any, like a learning curve per se, or anything that has surprised you early on.
No, yeah, no, that's great. I think as a young surgeon, you're just hungry, you're eager, you really want to get at it, right? You really want to be, in the OR by day two, right? If not day one, And so, what has humbled me is that it really takes time to build a practice, right? And so you want to be that person that says yes to everything. You want to be able to take care of patients. You want to be able to be amenable, affable, and able. Just like everyone has ever always taught you. But it takes a while to build a practice, especially in spine surgery. And so don't be over eager. Make sure you indicate patients correctly, and don't rush your indications just to get to the OR. I think that it'll come. So that's one thing that I would advise people that are just coming into practice for sure.
Yep. Solid advice. Solid advice. I can echo on all of that, especially the A's being amenable, affable, available, obviously, as well. So all those, I think there's like 4 A's. There's like an acronym for early physicians of what you need to be in order to build a practice. But I echo that on building a practice. And
Yeah.
so, switching gears, we're talking today about lumbar interbody fusion. I kind of just want to make up a case here, and then you can kind of walk us through some of the different things. So, say, you got a 55-year-old female, back pain for many years, referred to your clinics. You saw another physician who told her that she needs a fusion, and she shows up in your office. She says, I've had back pain, and I was told I need a fusion, and here I am. They sent me to you. What are some of, well, one, like, how do you explain what a fusion is? And then two, how do you go about examining them? Like, what kind of questions are you asking them? Like, what are you looking for when you examine them?
Yeah, so fusion, in layman's terms, is really just making two things become one, right? It's just like, it's another way of simplifying an arthrodesis. Our job is to make, these two mobile segments become one. That's the idea of fusion. And so fusion is usually indicated for only a couple things, really. It's really indicated for mobile spondylolisthesis. And you can accomplish this by regular posterolateral fusion usually. That's one way of doing it. That's kind of the gold standard. It's always kind of been the traditional way of doing it. Just recently with newer technologies and different indications, we've developed these interbodies which can go within these disc spaces, which is kind of what we're talking about today. So interbody fusions, again, are going to be something that we replace the disc spaces with, either with usually like titanium, some PEEK, or even some just like allograft, right? And so that's something that will take the place of it to help us achieve fusion in a different manner. The posterolateral fusions really depend on decortication and fusion of the facet joints themselves, or within the posterolateral gutters or within the transverse processes. So interbody fusions really depend more on this technology between the bones, and it can be in conjunction with this this posterolateral fusion as well.
The posterolateral. Yeah, that's one of the things I have to try to figure out or just learn. Like there are different areas of the spine that you're trying to get to fuse with each case, right? Like the inner bodies versus the posterolateral aspect of the spine. Actually, I know you have some slides. I'm going to try to pull them up here just so those that are listening have something that they can also take a look at and see that we're talking about. If I can find the button to share it here. So,
yeah.
To recap of what you were saying. So, in what cases, just like you just mentioned, like you mentioned posterolateral fusions versus interbody, are there any cases where you're just only looking at you only want the posterolateral part of the spine to fuse, or do you only want the interbody? Like, how do you decide what you want to fuse?
Yeah, so I think that posterolateral fusion is still going to be kind of the gold standard, right? A lot of physicians still out in the community right now will rely on posterolateral fusions, especially if you're not used to the approaches needed to accomplish an interbody fusion, and so that was kind of the mainstay of how fusions were done historically, right? And so, in order to achieve these interbody fusions, you have to manipulate the dura, you have to manipulate different organs to be able to access the disc space. And so that's not necessarily, known by, surgeons aren't necessarily going to be comfortable with that across all cases. So, again, if the tried and true way is this posterolateral fusion within the transverse processes and within the facet joints of the spine.
Okay. And so who is the interbody fusion for? Oh, I love it here. Interviewed, not for everybody. Who is it for?
Yeah. So again, you have to remember, fusion and surgery, spine surgery in general, has limited indications. It's for, the three goals of surgery will be to decompress, to stabilize, and sometimes to realign, right? So if you want to go to the next slide, I think this is a good kind of idea of when you should choose the checkbox that says interbody fusion as the correct test answer. So these are the few indications, right? So severe up-down stenosis, right? So if you can see on this picture all the way to the right, I have a sagittal cut of an MRI of the spine, right? And so if you're counting from the bottom, we have the sacrum, L5, L4, right? And so exactly right, there you go, that's your L4 body. And we're looking right into the neuroforamen of L4-5 right there. And so that's what we call severe up-down stenosis, right? And so the disc has collapsed so much so that the exiting nerve root, the L4 nerve root, is completely stenotic. We call that severe foraminal stenosis right there, right? And so you can imagine we can try to decompress it directly by, taking out the facet, where we're taking the bone off, the inferior facet of 4 and the superior articulating process of 5, and that will try to decompress that exiting nerve root a little bit. But the disc is still so collapsed that you might want something to almost, for lack of a better term, to jack up that space, right? So that there's a little more room for that exiting nerve root to kind of function. So that's what we refer to as severe up-down stenosis. So by creating an inner body to jack up that disc space, it'll create that extra room for that exiting nerve root right there. Yeah.
Okay.
Other indications will include like failed discectomy or reherniation. So you get to a point where you're doing one discectomy for a patient, right? They do well for a period of time, and then they reherniate again, right? And so at that point, you may choose to do another discectomy, right? And then you hope for the best. Hopefully they don't reherniate again, right? And so eventually, or they potentially might reherniate a third time. And at that point, it gets dangerous because there's scar tissue. You're at risk for another reherniation. So you might as well go ahead and get rid of that entire disc, and then in its place, put an interbody to function as that disc. All right. Another indication will be pseudoarthrosis revision. So say these surgeons tried to do a posterolateral fusion before, right, with decorticating the facet joints, decorticating the transverse processes, and no luck, right? They tried instrumentation, regrafting, still no luck. And so if that has failed, you still have a pseudoarthrosis or a failed fusion, then you can try to get fusion across the end plates themselves. So you have a greater surface area of fusion, right? So no longer just those limited areas of just across the transverse processes where you have to try to achieve a fusion throughout the muscle, that's between the transverse processes. But you have all that bone available across the disc space now on the end plates, right? So that's a much, much bigger surface area for fusion. Poor patient biology, right? So that's, an extension of pseudoarthrosis, right? And so if you think that this patient is already going to be at high risk for not being able to fuse, then you go ahead and just decorticate the end plates to get that increased area of fusion. And then restoration of alignment, right? And so sometimes you can develop a scoliosis, a degenerative scoliosis, because of uneven collapse of the disc space, right? The left side might be more collapsed, the right side might be more collapsed. You might even have this lateral listhesis because of it. And so you can address that, you can correct that by placing an interbody there to kind of even it out, restore the alignment. So all those, more or less achieve those goals of, decompressing, realigning, and then also being able to stabilize it as well.
Yeah, I like that, the decompressing and realigning. So you, just like you mentioned, I hadn't heard of the up-down stenosis before, but again, like you're looking on the sagittal cuts, and you're looking at basically right where that the neural frame and where you're seeing that narrowing there, and you're looking at the space, where the superior articular process, inferior articular process, and you're seeing that stenosis. Anybody that's failed discectomy, as you mentioned, pseudoarthrosis or revision, and the main things that I kept hearing you mentioning was that the surface area at the end plates, right, at the vertebral bodies, the top of the one vertebral body and the bottom of the other vertebral body, this gives you more surface area to allow higher chances of healing, right, or higher chances of bone fusing, which makes sense. And then obviously restoring the alignment. I remember when I was in residency going into a case, and like I was saying, when we started off, like I would read on everything, and you'd read on ACDFs and everything, but then you look and you'd see lifts, but then you see like XLIF and PLIF and all these different letters in front of the LIF. Like in LIF stands for interbody fusion. But can you kind of just break down, or at least let's start off with the ALIF that you described and go, maybe we can go from there. I've heard some horror stories on ALIFs gone wrong, but I also know that it's a very good surgery that can be done very well. So can you kind of bring us through what ALIFs are and the pros and cons for it, and when to use it and when not to use it?
Yeah, definitely. That's a great question, And so, the first and foremost thing you should do is kind of like introduce this to your patients, right? You can't just say, hey, I'm a spine surgeon, we're going to operate on your back, but the way we're going to do this is going through your belly, right? So they need to kind of be in the right mindset to be able to do this, right? So an ALIF stands for an anterior lumbar interbody fusion. So we're going through your abdomen to get to your spine anteriorly, right? And so to be able to accomplish this, it's not a one-man show, really. You really want to have an access surgeon, although, some select surgeons will elect to do it on their own, to this approach. So in order to get through this, you have to have this access surgeon who's comfortable mobilizing the peritoneum. So you're going to be retroperitoneal to access the spine, where you'll sweep the peritoneal contents to access the disc space, usually at 4, 5, and 5-1. Those are kind of the mainstays of an ALIF procedure. Sometimes, if the access surgeon is comfortable, you can get as high cranially as 3-4, right? And so, although you don't necessarily need that much lordosis usually, right? But it's a very, very, very powerful tool to restore lordosis, right? And so this is what, it's got the biggest surface area for fusion. You can imagine, TLIF, you have to mobilize the nerve roots. You have a very, very small window to kind of work around those nerve roots and the dura to be able to place a cage. Whereas here, you don't have to worry about those neural elements. You can just put a big, massive cage right in the disc space, and almost fill up the entire disc space entirely, pending you get that vasculature access that you need. So
Yeah.
my kind of algorithm is, if you need interbody fusion at L4-5, L5S1, and you have kind of a sagittal malalignment where the pelvic incidence doesn't match the lumbar lordosis that you need for that patient, ALIF is almost going to be the default unless there are some contraindications.
Okay. ALIF, again, like you just mentioned, you need a vascular. You're not a vascular. You need an access surgeon. To my knowledge, it's mostly like general surgeons or somebody that's very comfortable in the abdomen to help kind of move all those abdominal organs and the peritoneum out of the way. And those are good for L5S1 all the way up to L3, L4. But again, main thing, you're looking at the sagittal alignment when something's off, like the pelvic incidence versus lordosis, or that's when you're thinking of, okay, we need to get some lordosis. I need this to. Is this something, if you have a patient where does the patient biology contribute to this as well? Because you mentioned it for the other ones earlier, for when we might do a lumbar interbody fusion. Does it matter for biology? Like, would a poor patient biology push you more towards ALIF versus another lift?
Yeah, yeah. If it's the right patient candidate, if I know that they need bigger surface area for fusion, and I can get the 4-5 and the 5-1 disc spaces accessed, yeah, I think that for an ALIF would be the ideal operation, because such a much bigger interbody can be used in that situation, and you want to try to maximize every opportunity you can to get this patient to fuse.
Yeah, and is this something done? Like, how do you send this up in the OR? Are they in like any special beds or anything like that, or how are you doing this case? Like the
Yeah,
high
so this is a
tips.
great question. Yeah,
Yeah.
so you usually want to use kind of a radiolucent table to be able to get your proper X-rays. You're shooting through the abdomen at this point, so you want to make sure that you have a table that can accommodate the C-arm, being able to go lateral, shooting an AP, and not being stuck there. So usually, I think a general orthopedic C-max table will be fine. Some people prefer a Jackson table to be able to get the X-rays that they want. And then, in terms of setting up the bed and the patient, this is kind of a typical setup that we used. Patient's arm, patient is supine. They might have a bump under their sacrum to help them get access to the disc space a little bit better. You can see that there's an arm retractor for kind of being able to retract everything for us, and that's mounted to the table. The spine surgeon is typically on the left of the patient. The vascular or access surgeon is usually along the right side of the patient. And then the arms will either be, out, or one arm could be over the chest, depending on if there are, residents who want to become involved and you need a little bit more real estate. They're both generally pretty safe. And then, you want to keep them warm, obviously, with a bear hugger up top and sometimes below. But you want to have a relatively large exposure, right? So you want it from pretty much the pubic symphysis all the way up to the xiphoid, just in case, you have to extend it, God forbid, you can have bailouts, and so that's kind of how much real estate you need, to be honest.
Yeah, and speaking about bailouts and things that you may need, what can go wrong? Ideally, we do this case. Somebody comes in, they get us access. We go there, and then you clear out, you take out the disc, you put in the fusion. Everybody high fives. It looks great at the end. But what are some of the things that could go wrong that you should know about? Which when you know about it, it helps make sure you avoid those things.
Yeah, yeah. So, luckily, if you have a very proficient access surgeon, hopefully you can mitigate a lot of those complications. But I mean, this is spine surgery, but this is also major vascular surgery, right? And so, you can have a lot of bad structures in the way, and so this is a small diagram. You can see your aorta comes down and starts to become your iliacs. And that can be scary, right? And so, believe it or not, those don't get as injured as much as your iliac veins. So, those things are friable, they're collapsible, and so they're more prone to injury with just a retractor or just your, any instrument, right? Because the walls are a lot thinner. And so, if you have a bleed, I remember hearing stories in fellowship that if you have an injury to the vein, that's actually the catastrophic, injury, and so you want to try to avoid that rather than the arteries usually. But luckily, there's an access surgeon who is usually proficient taking care of these things, and so you're not alone. Other than that, the big test questions usually that you have to look out for are, retrograde ejaculation. You have to tell these to all your male young patients, right? And so usually you talk to your patients, you tell them the risks of this surgery for any procedure, but specifically in young males who are still looking to have children, to have families, you want to warn them that, you can potentially injure something, specifically the superior hypogastric plexus. And if that happens, they might still have an erection, but they might not have a real, ejaculation, right? It would kind of be retrograde at this point. And so there are ways to mitigate this. Obviously, you can avoid, injuring these neural structures that you see across the disc space. And then, the other way is to try to avoid using monopolar cautery, so I'll usually always tell my access surgeon to kind of either use bipolar cautery or avoid using cautery altogether to mobilize what they need to so that you can minimize this risk. And then you have these sympathetic chains that are kind of, along the disc spaces. They're kind of bilateral. And so that can, it can have some either temporary or permanent effects. It can, the test question that a lot of people will get is, say you injure a unilateral sympathetic chain, right? And so their foot starts to become warmer or colder. It's usually going to be warmer, right? Because the sympathetic tone is going to be not there. And so it's going to vasodilate. And so that leg will start to feel warm. And it can also start to look a little red too, because again, that vasodilation will cause it to look a little more erythematous, a little more swollen. So those are kind of things to look out for, things that you can be potentially pimped on, during cases as well. Then other things that are a little more obvious, bowel and bladder injuries. Obviously the retroperitoneum needs to be swept out of the way, and then your ureters are a little lateral, but also in the field of view. And then just closing, this is still major abdominal surgery, so you can still have, your abdominal wall hernias from this as well. So those are all things.
Yeah, I remember seeing questions on injuring, especially the retrograde ejaculation, and it's never like what is the complication. It's more they kind of describe what it is the patients are complaining about after the surgery, and you have to know that it's a superior hypogastric plexus. So yeah, those are good points. And what are the most common complications, right? Those are the unique ones when we talk about ALIFs in particular, the ureters, the sympathetic chain injuries that you just mentioned, which will have like the warm extremity, the vascular injury, the abdominal hernias. What are some of the other, more common things that the nurse may call you about, or that they may call your office 3 or 4 days post-op and say, hey, doc, is this normal? Like, what are some of those things?
Yeah, no, that's a great question. And those are, great test question like answers, but this is the more practical stuff, right? And I think that everyone should get to know this. Tell them, tell your patients about it. But this is still major abdominal surgery again, right? So you're mobilizing the peritoneal contents. And anytime that happens, you're going to have some kind of an ileus, right? So generally, I start my patients on a clear liquid diet to kind of let the bowels kind of resolve and start functioning on their own again. But otherwise, just let the patients know you're going to be constipated. You're going to be constipated for a while. We're going to be asking you all these weird questions like, are you farting? Have you pooped yet? For the first few days, and that's paramount to your recovery, right? Otherwise, patients will also get this significant swelling along their belly, and that's pretty common as well. And then if they're males, that swelling and that ecchymosis can run all the way into your scrotums. Scroti. We're not urologists. I don't know.
One of those.
Yeah, exactly. And so, just tell patients, this is also very common. The blood's got to go somewhere and it'll go away. Don't be too alarmed. Otherwise, your legs can become swollen as well, just like everything else, just ice and elevation. And then to prevent any hernias from manifesting, sometimes some patients or some surgeons will tell their patients to wear an abdominal binder as well.
Yep. And then, so those are all the the common things. Those are the questions that, especially if you're on call, or if you take call of the practice, if you're an attending, and your partner does spine stuff, that you may get calls about. So that's good just to know those common complications. How can you avoid some of those surgical complications that we talked about, right? Like, how do you avoid nicking the vessels, or doing some of these other things?
Yeah, so this is like everything in orthopedics and surgery really. You want to be prepared. You want to know what you're getting yourself into, right? And so the best
Yep.
way to do this, like we do for our general motto in orthopedics, right? Measure twice, cut once, right? So you're always preparing, making sure you know what you're getting yourself into. So the best way to do this is to study your preoperative images, and this is the best modality usually is this MRI here, right? And so we can see the great vessels, we can see where they bifurcate. Is it going to be directly in front of L4-5? Do we have a wide area to work at L5-S1, or are we going to have some aberrant vascular anatomy, right? And so just a good meticulous study of your preoperative imaging can do 90% of the work, right? Otherwise, just trust your partner. They're going to be usually very reliable. They've been trained in the bowels much more so than us, and so they're going to be able to get you out of a lot of trouble. Otherwise, you kind of want to be in and out as fast as you can, minimizing the retractor time. The faster you're off the great vessels, the less of a chance you're going to develop, the patient's going to develop like a DVT or something like that, a big clot, and then injury to all the other things that we just said were at risk. And so those are the big things. Other things to think about, as the spine surgeon, then, you want to, again, avoid using monopolar cautery. You want to avoid gouging the end plates to prevent subsidence of the actual inner body, and then risk that a failure of that fusion. And then, again, you want to make sure everything's in the right place. So using C-arm to ensure that the cage isn't too far, and going to impinge upon the neural elements.
Yeah, and so those are. I mean, that was a great explanation, overview of ALIF. Talked about all the the major complications, even the unique complications to ALIFs. So that's going at it from the front, right? And so if this, we're going like around the clock face here, and we move more close to the side. Can you talk about the other lifts, like the D, X, L lift? Like what? Like can we switch gears, and can you kind of talk to us about what those are and how those differ for the ALIF, and what are some things that we need to know for those procedures per se? And then what,
So,
again, the DL, alphabet soup.
yeah, alphabet soup, baby. So we talked about going anteriorly. That's the first way. And so
Right.
if we go just off to the side, or this is going to be all the way to the side. So if we're coming in from a lateral approach, right? So
Yeah.
there's a couple names for this procedure. DLIF, which stands for direct lateral interbody fusion. XLIF, which stands for extreme lateral interbody fusion, which is, again, a proprietary kind of a name that one company decided to use. And then a lateral lumbar interbody fusion, all analogous, all meaning the same thing, all going through the transverse process, transpsoas, I'm sorry. But these are great procedures.
Okay, and so you talked about when you were talking about an ALIF, right? When we were gonna pick somebody for an ALIF, somebody that obviously needs to get fused, but also when you're thinking about correcting some of the sagittal alignment, right? In patients where their incidence there's something sagittally off, right? Because those are powerful for getting lordosis. You can, and correct me if I'm wrong, you can get bigger cages maybe in there than you can with some of the other types of lumbar interbody fusion. So when do you use the D-lift, X-lift, or L-lift? It's this kind of this lateral interbody fusion. When do you use this part?
Yeah, this is great for, again, test questions or just like literally, clinical practice as well, right? So
Yeah.
ALIF has its own indications. L-lifts are, have their own indications as well. So for X-lifts, D-lifts, L-lifts, you're going to be limited by what you have access to from the lateral side, right? And so the iliac crest usually rides high, mainly around, L4-5 is kind of the disc space that it lies. Some people might have low riding iliac crest, some may have iliac crest that ride a little higher, right? And so the sweet spot which is going to be the area between the iliac crests and your ribs. Usually it's going to be, L2-3, L3-4. Those are your kind of main disc spaces you want to kind of tackle, right? But again, your L4-5, you can kind of do some tips with like bumps, with breaking the table to be able to get you access to the L4-5 level. But, and the patient's anatomy might not be amenable to that, right? So it's a very individual case-by-case basis. You certainly won't be able to access L5S1 in the traditional direct lateral interbody approach. And then, some patients, some surgeons might push it. They might, try to go as high as, T12L1, L1-2, through the ribs, really, between ribs or through the actual ribs by cutting the ribs. But again, the sweet spot is going to be 2-3, 3-4.
Yeah, I remember seeing a couple of these procedures when I was a resident. I mean, to me, it was pretty cool. Like, you go down there, you just kind of move some stuff out of the way. You put the tube down there with the light, and like you can see everything. It was really cool.
Yeah,
I know. I just explained it like a fifth
or
grade,
what
like,
you can't see.
but right.
Yeah. I know. Dr. Syriac loves this procedure. I know.
Yeah, exactly. Syriac. I saw a good amount with Syriac. Yeah, he was actually a guest on this podcast. But yeah, Dr.
Oh yeah, exactly
Dr. Syriac,
right. Yeah. Great guy.
Okay, so and I guess what are the advantages for using this lateral interbody fusion? They're like the direct lateral XLIF. What are the advantages for this?
So for the right patients, this can be super, super minimally invasive, right? And so, the incision for an ALIF can be, this big, which is a few centimeters. Depending on how much you need, right? But for LLIFs, all you need is, an incision that's pretty much big enough for your inner body. So just 2 or 3 centimeters, honestly, right? And so this is also kind of like muscle sparing. It goes through muscles rather than cutting through muscles. So patients can really, because of this, have a really good outcome, have really minimal pain. Otherwise, you can, again, use a huge interbody for these disc spaces, right? Because you're not confounded by the neural elements. So going through the psoas, going through the lateral approach, you can really get a really high interbody to really jack up in that disc space and get indirect decompression. And then because these interbodies are so big, you can get an increased surface area to be able to achieve that interbody fusion as well.
So who is this not a candidate for? What patients are like, we probably should not do, or we shouldn't take this approach to doing an interbody fusion? Like, we shouldn't do the XLIF approach. Are there any people who are like, maybe this person we shouldn't do it for?
So again, you shouldn't do it for patients who need L5S1.
Right. Yep. Because the iliac.
Exactly. And then L4-5, again, is case-by-case basis. So some patients might not have the iliac crest that's going to be amenable to it. But then, again, the most important thing, once you decided, maybe I can do it for this patient at L4-5, maybe I can do it at L3-4, you're going to want to study their preoperative images, see if they are a candidate, right? And so you're going to look at this. This is, again, an axial cut of their MRIs. To see where the vessels are, right? And so not just the vessels, but the lumbar plexus. This image all the way on your left, you can see outlined in white is going to be the psoas, which is usually going to be pretty lateral to the disc space, which is that central black part, right? That central black oval part. And so, if it's riding a little high, meaning they're going anterior, they start to look like ears on this inner space, right? And so what we term this as is a Mickey Mouse psoas, right? If you can see by these cute drawings, it has that kind of outline of the Mickey Mouse kind of face, right? And so when it is that anterior, it pulls on the lumbar plexus, right? And so that's what's outlined in that those yellow boxes. And so when you go through the psoas, you might actually be injuring, things that you don't want to injure. And when you're retracting, you could be, retracting against the lumbar plexus, which will leave, neurological deficits for the patients. And so if you see this kind of psoas, you want to actually try to avoid it if you can.
So ideally, remind me. So again, ideally, where would you like to see the psoas on your cuts? Like, is this like you see it and you're like, yes, thank you. You know, you relax a little bit. You know, you're still vigilant, but you're like, okay, this is better than the Mickey Mouse, the dreaded Disney.
Yeah, yeah. So, so you can see the Mickey Mouse ears, have the psoas that are all the way up here as his ears. But imagine if, I was the inner space. You want the ears to be kind of along the lateral edges right there.
I'm trying to think of another Disney character to name
know,
after
right?
who is normal. Goofy? Nah,
Maybe
I don't know
Donald Duck, I
who's
don't know. Definitely not
whose
Goofy.
ears dropped down. I don't know. Maybe I'll think about it and maybe you can write it up or have somebody write it up.
Yeah, yeah. Pluto ears,
Gosh.
maybe.
Yeah, maybe. And so, and how do you position these? I remember the few that I did in residency, but how do you position these, and any tips and tricks for this case?
Yeah. So, we were talking about this, who's a patient, what disk spaces are going to be able to be accessed. So you want a table that ideally breaks, right? So that means usually an orthopedic table, a CMAX table that can, Trendelenburg, reverse Trendelenburg, kind of just at the midpoint of the bed, so that it can break the ribs on the same side as the iliac crest, right? And that sometimes gives you access to the L4-5 when it is otherwise going to be in its way. So that's the one thing. And then usually, traditionally, the patient in the right lateral decubitus position, meaning the right side will kind of be on the bed, and the patient will have the left side facing upwards. And then the surgeon will usually be operating from posterior. That's usually just by convention and because it's easier to access the disc space through that plane. And then you want to make sure everything's padded, right? So a lot of things can be injured by neuropraxia, right? And so in any orthopedic case, you're worried about all the other nerves, right? So you want to put ample padding between the arms, you make sure the elbows are a little flexed, and you want to make sure that the perineals are going to be well padded as well, and then the actual to prevent any brachial plexus injury.
Yeah, and then I remember one of the things beforehand was making sure that you have like good X-rays, in that you can see everything that you need to see. And so when you're setting up for this case, what do you look for, right? Like how do you look and you say this is exactly what I'm looking for in the X-ray? All right, scrub, let's get this going.
Yeah. So that's like, again, 90% of the battle right there, is going to be able to get, great x-rays. And so you want to have no parallax, right, for each disc space that you're going to be addressing. So that means the end plates are going to be completely sharp. This is not a great slide, unfortunately. I meant to, it's supposed to be a video, but
It's okay.
So this slide should have been what not to look for.
That's great.
So you want to have really crisp end plates so that you don't have parallax, so that you can access the disc space immediately. You're open up that dilator immediately to minimize retractor time, and so that you're not, going into the actual vertebra. That would be disastrous, right?
Yeah, that'd be
operating
terrible.
Yeah. So what you want is on an AP to be able to see, both pedicles lined up. You want to see that the disc space again is going to be crisp and clear, and then on the same side, on the lateral, you want to see again the end plates are going to be clear, and then the facets and transverse processes and the pedicles are all lined up. So you want to see that that's true at every single level that you're operating on, so that the C-arm can literally just go from AP to lateral just seamlessly.
Yep.
To maximize the efficiency and reduce retractor time, which is huge for this procedure.
Yeah, and so I remember, just briefly, not too long ago, you talked about the ALIF and you talked about the unique complications for that, right? You talked about the sympathetic chain injury. You also talked about the retrograde ejaculation with those hypogastric, with the hypogastric plexus. What are some of the complications kind of more unique towards this XLIF, right? Or LLIF, DLIF, the lateral approach.
Yeah, the lateral. There you go. Yeah.
The lateral approach.
Yeah, so I have a pretty great slide that's going to be useful for test taking purposes, but we'll do this one first.
Oh,
So,
this one. Oh
that
yeah.
yeah, that's the
Oh
maker.
man.
Yeah, that's the money
That's it.
maker for
That's
sure.
it.
And
That's
this
it.
is something I don't think they're going to necessarily test you on completely on like an in-training exam, but certainly, this is pretty comprehensive. You should definitely take a look at it. Yeah, it was worth the time making it, right? So, all these nerves can be injured during the procedure. Sure, it's very minimally invasive. It's, potentially painless, but it is wrought with complication, right? So all these nerves can be injured because of the lumbar plexus and where it drapes, where the psoas is. So first, yeah, you don't have to worry about that. Yeah, we'll just go through this. The femoral nerve, right? L2 to 4. You absolutely have to tell patients that they can potentially wake up with this quad weakness, right? There is inability to lift their leg up. They feel like they're dragging their leg. They might even say that their leg isn't working, right? And so this is a known complication. Again, it's directly related to retractor time. You want to try to ideally keep it to less than 20 minutes per level. And then just making sure that you're clear of it when you're dilating and getting these signals, right? And so your other nerves will be, the obturator nerve, same lumbar plexus. Some patients will have this numbness or this weakness along their medial thigh. Genitofemoral nerve, right? This is the nerve that you will get asked what pierces the psoas, right? It's going to be this genitofemoral nerve, and it usually lies anterior to the psoas. So I've seen that, on a couple of test questions before.
Yeah, me too.
And yeah. So what that will leave patients is this numbness and sometimes even pain along their groin, along their genitalias, and their anterior thighs as well. And then big thing that you have to tell patients, you're going to wake up with some kind of thigh numbness, right? Again, that's going to be related to retractor time, and that's because of injury to the lateral femoral cutaneous nerve, whether it's due to the retractor or direct injury to it. Then your iliohypogastric or your ilioinguinal nerves, again, can cause this sensory loss to your groin and lower abdomen. And then, the other thing that can also be injured in this is your sympathetic chain again, right? And so you'll have those same instances of your one leg feeling warm or vasodilated and looking a little red, or edematous can potentially be injured because they are along the sides of your vertebrae as well.
Yeah, one of the big things you've been repeating is definitely minimizing retractor time, because you don't want anything causing that neuropraxia to the nerves. Do you use any neural monitoring when you're doing these cases?
Absolutely. This is something that again, it depends on your environment, whether it's in the litigious, city, or, just in a small community, it depends on that kind of environment. But I'd say almost 99% of these cases are going to be monitored, right? So you're going to want to use EMG monitoring to make sure that your nerves, even if you don't visualize them directly, are going to trigger these EMG responses. Greater than 10 is what you want to hear from your neurophysiologist. And you're going to look, inferiorly, superiorly, anteriorly, posteriorly, to be able to map out this lumbar plexus without necessarily visualizing it on your own, right? I talked about this before. You want to use the retractor for less than about 20 minutes expanded per level. And then, again, you want to be able to, operate where it's going to be safe. So that means, studying again the MRIs and the CT scans beforehand, but also you want to try to, respect the anterior half of the disc space and make sure that you don't injure, where you expect the lumbar plexus to be. Okay, and then to be able to make sure that the patient is properly positioned, which means breaking the table, flexing the hip to be able to relax the psoas as well, will help to kind of achieve this operation.
Yeah, solid. Great rundown and overview of the lateral interbody fusion. I swear, I wish I had this when I was like a second year resident. This would have made things so much clearer for me.
Yeah.
Especially just explaining like the XLIFs. I was like, where is this coming from? But so moving forward, right? So we talked about going straight anterior, ALIF. We talked about the lateral interbody fusion. So kind of working our way, going more and more posterior. What's the next lifts, the next set, and then when do you choose those? Like, what makes those different?